Hi, thank you again for giving me the opportunity to deliver this talk. My name is Azeez Salawu, Clinical Fellow in the Toronto Sarcoma Program, and I'll be presenting a talk titled Chemotherapy When the Usual Drugs Don't Work. The focus of this talk is going to be on primary malignant tumors of the heart. The vast majority of these are sarcomas, so essentially I'll be presenting a talk on primary cardiac sarcomas. I know most of the previous talks have been on tumors from other sites that metastasize to the heart. And I'll be providing an overview of systemic treatments, including the usual chemotherapy, as well as other chemotherapy that's available for treatment of this disease, targeted therapies and immunotherapies, and I'll finish up with a case presentation. So malignant tumors arising from the heart are very rare. The estimated incidence is quite low. No studies have shown more than 0.03%. They do have a high propensity to metastasize and are regarded as a systemic disease at presentation, even when disease is only localized on a radiological basis. They have a tendency to metastasize to the lungs, to the liver, and also to the brain. The prognosis for cardiac sarcomas, unfortunately, is quite poor, with median survival ranging from 9 to 27 months. And adequate surgical resection is probably the most important prognostic factor. That means an R0 resection and multimodality treatment, which involves surgery, chemotherapy, plus or minus radiation, is advocated. And this is advocated to be done at specialist centers that have a relatively high volume of this disease in order to get the best outcomes from patients. And there's several retrospective reviews that support this. Unfortunately, location matters with sarcomas, and as you can see here in this busy slide, in highlighted, soft tissue sarcomas of the heart have a relatively poor outcome in terms of 5-year survival compared with soft tissue sarcomas at any other site in the body. In terms of histological subtypes, the cardiac sarcomas can be essentially of any histologic subtype, but we see most commonly angiosarcomas, possibly intimal sarcomas, but essentially any other sarcoma is possible. I've put here about 6 retrospective case series that showed different histological subtypes of sarcomas, showing the wide range of possible sarcomas, including synovial sarcomas, leiomyosarcomas, liposarcomas, etc. Unfortunately, there's a lack of prospective evidence, as you can imagine, with a very rare tumor like this. And the approach to treatment is largely extrapolated from the systemic treatment that is used to treat sarcomas at other anatomic locations. There's several considerations here in terms of histologic subtype. That's still probably the most important determinant of what kind of systemic treatment we choose. The location I've put here because quite frequently, because the heart is such a vital organ, some localized treatment to the heart is usually part of the management regimen upfront for these patients. There's also patient factors in terms of their fitness and ability to tolerate systemic treatment. Biomarkers, where available, there's very few of them, and I'll talk about these as we go on. But biomarkers where available are encouraged, and it's also encouraged in these tumors to do genomic profiling when available in order to identify possible treatments. And we employ phase 1 trials, which I'll go into a bit later as well. So the usual drugs for systemic treatment of primary cardiac sarcoma tend to be adriamycin-based chemotherapy. We use combination therapy generally if patients are fit enough, because this is an aggressive disease. The most common partner for adriamycin is ifosfamide, and this is suitable for the vast majority of histological subtypes, such as angiosarcoma, intimal sarcoma, leiomyosarcoma, synovial sarcoma. The response rates vary from 25% in general to up to 75% in some neoadjuvant treatment for cardiac sarcoma, some case series that have been presented. The responses, unfortunately, are often not durable. Progression-free survival is about 7 months. And in some specific histological subtypes, the partner for Adriamycin can vary. Like, for instance, dacarbazine may be favored as a partner for Adriamycin in leiomyosarcoma, or combinations such as VAC may be considered for rhabdomyosarcoma. Following, when disease recurs after Adriamycin ifosfamide, or when Adriamycin ifosfamide is just not feasible because of possibly patient factors, there's other chemotherapy options that can be considered. These tend to be, again, drawn from other histologic subtypes of sarcoma at other anatomic sites. Gemcitabine plus or minus docetaxel is probably the most popular of these, with relatively good response rates, but I think in general it is felt that Adriamycin ifosfamide, is a bit superior to gemcitabine docetaxel. Gemcitabine as a single agent can be considered as well in patients who are not fit enough for the docetaxel. Trabectedin can be used in certain subtypes such as leiomyosarcoma. Dacarbazine or eribulin are also quite typically considered. It's important to note here that even though we see angiosarcomas in the heart relatively commonly, we do not use paclitaxel in general to treat angiosarcomas of the heart, because the response rates are poor, can be as low as 14%. And paclitaxel is the preferred chemotherapy regime for cutaneous angiosarcomas, which are typically on the face in elderly male patients and have a very different biology in terms of etiology, as well as even molecular characteristics. There's emerging evidence that these tumors have a high tumor mutation burden and response to immune checkpoint inhibitors, which is slightly different from the cardiac or visceral angiosarcomas. So it's important that we don't generally use paclitaxel in treatment of cardiac sarcomas. Next is targeted agents. We know about pazopanib based on the phase 3 pilot trial. And we know that for certain subtypes such as synovial sarcomas or intimal sarcomas, targeting angiogenesis with drugs like pazopanib has been shown to be quite efficacious. Regraphenib is another drug that's shown evidence in phase 2 trials, such as the REGOSARC trial, to be of use for treating these tumors with similar median progression-free survival to pazopanib in that trial. So this is another area where we can use an oral treatment to control this disease systemically. Emerging targeted agents include things like the NTRK inhibitors, which are tumor agnostic, so but they are biomarker-led, which is quite good. We get very high response rates. Unfortunately, NTRK fusions are quite rare in adult sarcomas, including cardiac sarcomas. Regraphenib is now FDA and EMA approved, and you can see here on the right the waterfall plot that shows the very high response rate that you can see in suitable patients, which also comes back to the fact that genomic profiling of these tumors is quite important in terms of looking at all possible treatment options, because this is a highly effective treatment, albeit rare. Next is mTOR inhibitors for certain sarcoma subtypes, specifically the epithelioid hemangioendotheliomas or PICOMAs. In fact, some retrospective studies have shown higher response rates compared with chemotherapy with these drugs. And On the right side, there's some recent evidence presented at CTOS late last year, that shows that an albumin-bound formulation of sirolimus and absirolimus is quite efficacious, and also shows a predictive mutation with TSC mutations, showing high evidence of efficacy. So again, this comes back down to the importance of genomic profiling for these patients. Another emerging treatment is selinexor, again presented at CTOS late last year, which showed some evidence of progression-free survival advantage in liposarcomas. And these can occur in the heart, so that would be another treatment option. Selinexor can be associated with quite a bit of toxicity, and there are ongoing studies, including here at our center, to look at alternative dosing regimens and see whether we can improve this toxicity. But this is certainly an emerging treatment that can be used for control of sarcomas as well. The selinexor targets exportin, which is a specific protein that works in the trafficking of tumor suppressor proteins from the nucleus, and helps to reactivate these tumor suppressor proteins and improve apoptosis in the tumor cells. Another targeted agent that's coming on stream with promising evidence is MDM2 inhibitors. These have been shown to have efficacy in liposarcomas in a phase 1b trial, as shown here last year. And we also have quite good evidence that MDM2 amplifications are quite common in intimal sarcomas, which are a common subtype for cardiac sarcomas. So the presence of MDM2 inhibitors on genomic profiling might point one in that direction as a treatment option after the usual drugs do not work anymore. Finally, we go to immunotherapy. The immunotherapy checkpoint inhibitors have changed the face of medical oncology in the last few years. And even though it's been largely disappointing, there has been some signals of some soft tissue sarcomas that respond to anti-PD-1 agents. I think notably among these is alveolar sarcoma of soft parts, the ASPS, which have shown quite good overall response rates, whether alone or in combination with anti-angiogenic agents such as axitinib. And we've also seen in combination studies of ipilimumab and nivolumab, responses were seen among angiosarcomas, undifferentiated pleomorphic sarcomas, leiomyosarcoma, and fibrosarcoma, making this something to consider among these tumors as treatment options. There's further combination studies that are ongoing. And something that has made quite a lot of waves is cellular immunotherapy, which has been exploited in certain sarcoma subtypes, such as synovial sarcoma, mixed liposarcoma, that express specific antigens like the NY-ESO1 or MAGE-A4. Excuse me. Targeted T-cell therapies, adoptive T-cell therapies, whereby T cells are isolated from the patient and re-engineered, usually by a viral transduction to express specific T-cell receptors that recognize these antigens, and then the cells are expanded and reinfused into the patient to develop an immune response. And two promising trials in synovial sarcoma that has previously been treated with the usual drugs of adriamycin and ifosfamide have shown quite impressive results with overall response rates of 50% and 44%, as you can see on the screen. The limitations, however, are that these patients have to be HLA-A2 positive. This is rare in non-Caucasians. And also, the durable responses are usually only seen when the treatment is preceded by lymphodepletion, which can come with the side effects of prolonged neutropenia or bone marrow failure. There's also the risk of cytokine release syndrome or the neurological symptoms, now commonly described as ICANS. But these are, they are considered to be safe. They are effective treatments for these side effects. And this opens up a new range of possible treatments for patients with synovial sarcoma. There's ongoing phase 2 studies to look at the efficacy of these treatments in more detail. So I'll move on now to a case presentation for a patient seen here, 49-year-old gentleman who presented in July of 2018 with breathlessness and exertion for about a week and some chest pain. He quite rightly had a suspicion of a pulmonary embolism. The CTPA was negative, and so he was discharged. In his background, he had no significant past medical history, apart from an allergy to amoxicillin. He lived with his wife and 2 children, and generally had a healthy lifestyle. About a month later, he represented with further shortness of breath, and an echocardiogram at the time showed the pericardial effusion with tamponade, which was drained. The cytology was negative, and it was suspected that he had possible viral pericarditis and was treated with aspirin and colchicine. But he was admitted again with collapse a few days after, with recurrence of the pericardial effusion, and another 2 liters of bloody fluid was drained with a pericardial window now put in, but the tissue again showed no malignancy. This just highlights how difficult the diagnosis of such a rare disease can sometimes be. He had further chest pain and eventually had a CT scan of the chest on September 6th of 2018, which showed a rounded mass in the right atrium measuring up to 6 centimeters with extension into the right atrium. It was initially thought to possibly be a right atrial myxoma, but he was also noted to have mediastinal lymphadenopathy and pulmonary nodules that were in keeping with metastases. And he went on to have dedicated cardiac MRI that showed the full extent of the tumor, which was infiltrating the right atrium into the cavity and involved the right coronary artery and tricuspid valve. And a CT-guided biopsy from this mass showed by cytology, histological and immunohistochemical evidence of an angiosarcoma grade 3. And this confirmed that the mediastinal lymphadenopathy and bilateral pulmonary metastases, bilateral pulmonary lesions were indeed metastases. So quite rightly, he was referred to a high volume center in Toronto and underwent tumor board discussion. He was treated upfront with doxorubicin and ifosfamide for 6 cycles and had a partial response. But unfortunately, he didn't have resolution of the lung metastatic disease. So what did we do next? We changed his treatment to gemcitabine and docetaxel. And unfortunately, even despite 6 cycles of this, he had further progression in the lung nodules. And at this point, we had exhausted 2 chemotherapy lines. And so he was enrolled in a phase 1 clinical trial of immunotherapy with interleukin-2 in combination with an anti-PD-1 drug in July of 2019. He had stable disease in his lung nodules, but an increased size of the right atrial mass. And so in December 2019, he was referred to our radiation oncology colleagues for consideration of treatment to the right atrium where there was disease progression. And he had radiation treatment to the right atrium and the mediastinum, which allowed him to go back onto systemic treatment with Calyx, which was controlling the disease at other sites. And I can report that up to October of 2020, which is more than 2 years after his diagnosis, his disease remained stable on Calyx. So what this case highlights is the possibility of additional treatments after first-line doxorubicin ifosfamide, and the fact that some patients who are young and motivated can sometimes actually tolerate and have disease stability through several lines of treatment. And so in such patients, it's important to have as much information so that we can sequence treatments as well as possible. A patient like this would certainly benefit from genomic profiling of his tumor to see if there's any other systemic treatment options that are available. He is currently not under our care at this center anymore and has returned to Quebec to his original oncologist who's managing him there. So in conclusion, there's a range of new and emerging treatments beyond the first-line AI for primary cardiac sarcomas. Molecular profiling, I cannot overstate, may identify additional therapeutic options, but definitely more high-quality evidence is needed, and this can only come through improved collaboration with national and international patient databases such as the CANSAC database, which will provide high-quality retrospective data to help us move things forward. In terms of prospective trial design, these have to be multi-center because of the rarity of this disease, and it will be useful for them to be histology specific and biomarker driven in order for us to get the best quality evidence out there. Translational studies attached to these trials will be important in order to identify new targets. And one should also not underestimate the value of referring these patients to phase 1 clinical trials, as this is where sometimes some unexpected therapeutic signals are seen, even though this is infrequent. Thank you very much for listening.
Thank you very much for discussing a very, very difficult problem that exists in the world. I'm always amazed at the lectures from the oncologists about the chemotherapeutic trials. All of the past presentations of the Toronto Cardiac Tumor Conference are online. And if you go back to the very, very first meeting, there's a very interesting lecture about chemotherapy for cardiac sarcoma. And it's almost a mirror image of what was said at that time. It's very, very difficult to find chemotherapeutic agents that have a long-lasting effect. One of the things that we see as very poor outcome, disease-free survival is very poor in all of the chemotherapy trials. What you didn't show is the small numbers of patients in each one of those trials, very, very small. And you're absolutely correct that not just the national database, as Dr. Reardon said this morning, but Dr. Reardon and Dr. Farku said, but we really need the whole world to come together and help us to deal with these and get more patients enrolled. If you have 7 patients in a trial and it's an international trial, it tells you that the outcome is not going to be good because there's not enough patients to really understand what's happening. You mentioned genetic sequencing and genetic profiling more than once in your discussion, and I'm going to ask Mike Seidman about genetic profiling, how difficult that is, especially with small volume tumors that we have. Again, I know it's funny that I've known most of those patients, partly because most of the speakers are from Toronto. I've known all those patients, and this particular patient you saw in Patrick Rogala's lecture, because he's one of the first ones I sent to him to biopsy. How difficult is it to get to this genomic profiling in a small piece of tumor?
Yeah, it's a great question. The reality is what we need is obviously way less than what we used to need. The current extraction techniques and the current capacity for next generation sequencing has considerably improved our ability to this effect. Also the addition of next generation sequencing based techniques for translocations. There were several translocation targeted therapies mentioned. That also requires considerably less material than some of the past techniques have, and doesn't require cells quite as intact and robust as they did for fish, for example. So the reality is most of the biopsies at UHN are yielding enough molecular material to guide therapy, but it is not clear to me that that is widely available yet. There's then also the question of how much testing to do. Our centers do a fairly targeted panel based on things we have therapies for. And when you start getting into more and more trials, you're going to have to test more and more stuff. So that's definitely a set of conversations you have to have at each center, including the option of sending it out. There are a number of commercial entities out there that provide varying levels of information. And, the reality is you take what you can take for the given patient, and we try to tell you as much as we can tell you.
When we do genetic profiling, so you're not doing the whole genetic, you're not doing the whole genome, you're just doing specific known sequences.
Correct. Right now, I think the oncology panel is somewhere around 20 genes in Ontario. Give or take, there is an experimental profile that I think is about a dozen more. The center where I trained had implemented a 1,000 gene panel the year I left. The reality is of those, no more than 25 are clinically actionable, even as today, 10 years later. Another 20-ish are grounds for trial enrollment. All of the rest range from theoretical trial enrollment to biologically interesting at best. So you have to be cautious when you get to the really big panels. When you're dealing with 20-ish genes, it is a limited sequencing technique. When you break 100, it frequently becomes more cost-effective to test the entire exome and just tell the computer which things you want to know. But that also makes trials easier for the things that you haven't asked for yet. And I will say germline sequencing superimposed on that is of variable yield depending on the amount of material.
Can you do
therapy? Yeah.
Can you do any of this testing in blood?
Isolated tumor cells, circulating tumor cells, in theory, are a source of material. Ariba, I'll come back to your question in just a second. I do not know if it is up and running robustly at UHN. The problem is that the tumor has to actually shed the material. So carcinomas are reasonably well studied in this regard, lung cancer in particular. I am not familiar with any data on sarcoma. That doesn't mean there aren't any. Albie might be able to speak to it. In terms of T-cell therapy profiling, the Foundation One basically does everything, including the thousands now of genes, all sorts of calculations. But as you alluded to, a lot of them are research level, so clinical trial level. In terms of T-cell therapy, most of what we actually do is IHC based. It's really the do they express or not, and then of course the irony being for most tumors it doesn't matter. The therapies seem to work no matter what, or don't work no matter what. But in terms of genomic profiling for response to T-cell therapy or any of the immunotherapies, I don't think it's very robust yet, in my opinion. So I think you're still looking at things that need a lot more work.
Can you educate us what Foundation One is?
Yeah, Foundation One is a company that does a absolutely massive genomic profiling. They actually developed out of a few different centers in parallel to when I was training. They test a very similar panel. I think it really is approaching 2,000 genes now. It is a next generation sequencing based panel. Basically, as they validate a gene, it gets added because I believe they are using exome backbone. They also are the people who sort of popularized tumor mutational burden. Although I have to admit, I don't personally know their algorithm for that, so I can't comment on whether it's the robust ones or not. And they continue to introduce more and more assays. My only footnote with them is their commercials, so I don't know that they are driven by resource utilization questions. So in Canada, we're asking a slightly different set of questions when we implement our own tests. I have no idea whether or not in that setting, funding to send out to Foundation One is an option. In the US, I will say that centers that don't have their own such profiling pretty routinely are using Foundation, but it's billable.
One of the other questions has to do with adriamycin or doxorubicin.
Yes, I can answer that if that's okay. This is Azeez Salawu here.
Replace it. Repeat the question in case people can't see the question.
Yes. So the question is, are the adriamycin doses in the cardiotoxic range, the adriamycin doses that we use for treating cardiac sarcomas? The answer is they're supposed to be lower than the cardiotoxic range. So we would still limit the lifetime dose of adriamycin as we routinely would in any other patients. We typically use 75 milligrams per meter square of adriamycin per cycle and keep it below the allowed lifetime dose. In general, we use the same dose when we combine with ifosfamide. Quite frequently, when we treat cardiac sarcomas, we are aiming to get as good a response, so as much tumor shrinkage as possible, just because of usually the location of the primary tumor. And so the best evidence for shrinking sarcomas of any kind is a combination of adriamycin and ifosfamide. But we would use a standard range of about 75 milligrams per meter square to achieve this. Do we monitor the cardiac function while we do this? It's not done in all centers, but in our center, we routinely do MUGA scans, radionuclide scans to monitor the ejection fraction as we treat. The last part of the question, I'm not quite sure I understand. If you don't mind repeating it, it says, given the low PFS.
I think what he's trying to ask is that the mortality rate of the natural course of the disease is very, very high.
Yeah.
And do you really need to?
So who cares if you develop dilated cardiomyopathy 10 years later?
5 years to kill you. That's a big question.
It is a good question. But sometimes our patients develop cardiomyopathy during the treatment quite quickly after they start adriamycin. So we feel that it's important to monitor, at the very least, have a baseline and at least one more check of the ejection fraction.
And so that's if a person doesn't have a fall off in ventricular function, is adriamycin, the combination of adriamycin and phosphomide, so good that you would like to keep it if it wasn't for cardiotoxicity? Should I be, at the time of a cardiac resection, I can give the heart whatever cocktail of medications you want to give me, and I can collect it all at the coronary sinus, so zero enters the body. I can take the heart out, as Dr. Reardon says, do an auto transplant, pour some medication, whatever toxic medication you want to give me, and soak that heart with the highest concentration you can ever believe. If it didn't matter, is adriamycin really that good?
I'm not sure. I suspect that would probably be toxic to the heart. There have been studies to look at the exposure of the heart to adriamycin. So I think this was touched on in the talks last year, whether to give it as an infusion over time or to give it as a bolus. Right. In terms of the exposure of the heart, and it doesn't seem to make any difference. The bolus treatment seems to have the same efficacy as prolonged infusion. But try as hard as we can. It's been about 50 years since adriamycin was established in sarcomas, and unfortunately, we're still yet to top adriamycin in terms of efficacy for sarcoma treatment.
When a person has a early drop off in ventricular function, A, how long does it take? And B, do you drop the adriamycin at that point, or do you go to a fuller dose, or do you change to a continuous infusion?
Generally speaking, if they have a drop off in ventricular function, we would
early loss.
Yeah. For early loss of ventricular function, we would generally stop adriamycin. and give an alternative.
And if that's going to occur, how fast does it occur?
It's not very common, and in terms of when it occurs, it tends to be variable. Some patients will have it early by the second or third cycle. We can already see evidence of it. I've seen patients who had one single treatment and their ejection fraction dropped to 20-something%, whilst others, usually it's after they've finished all 6 cycles of treatment that they then start to have heart problems. So it's very variable.
So when do you look at ventricular function then?
So we look at it at, we look at it at baseline.
Yes.
We try and aim for at least ejection fraction of 50%. We're happier with 55 in general. And we usually do another Mugger scan after 3 cycles of treatment to make sure that the ventricular function is holding.
And if the patient has normal ventricular function at the end of their 6 courses of chemotherapy, and they have something like a cardiac sarcoma, which, as you've shown, has a horrible outcome, especially if somebody I'm not going to operate on because they have a disease elsewhere, and they have normal ventricular function, would you continue IA into phosphomide and
Yeah, that's a good question. There's a lifetime limit to the dose of adriamycin that we can give.
Why is that?
So historical studies have shown that above a certain cumulative lifetime dose, the risk of cardiomyopathy is higher. Right. And so generally, we're not even allowed to exceed those. To exceed
you
those.
Realize I'm pushing you hard on the topic I know a little bit about.
Yes.
I mean, it's one thing to have a peripheral tumor that responds to adriamycin, like an osteosarcoma or something like that, where a person you would hope that they would they would survive for many years. But when you have a primary cardiac sarcoma, which has such a dismal prognosis, do you ever go beyond that lifetime dose?
Well, we have liposomal doxorubicin in the form of Calyx, which is what we tend to go for. So when they've had 6 doses of doxorubicin, our practice in this center at least is to continue with Calyx if appropriate. So if they've responded to doxorubicin and we want to continue that treatment, we'll give Calyx.
Liposomal, is that what Calyx is?
Yes, it's a liposomal formulation of doxorubicin, which is supposed to have less cardiotoxicity.
Go ahead.
Sorry. Occasionally, we'd use cardioprotective agents like dextrosane, but that's not very common practice in our center. Some oncologists are more comfortable with using it. Some oncologists are not. Some centers use the cardioprotective agents routinely for all their patients on doxorubicin.
And can you talk a little bit about, you spoke a little bit about efficacy of continuous versus bolus adriamycin. Can you talk to us about continuous versus bolus adriamycin? What I'm getting at here in this all of this discussion is that it seems as though nothing works as well as the bisphosphonate adriamycin combination. I'm going to ask you about the immunotherapy. That's very interesting. But what tricks do you have that will prolong the dosage or reduce the effects of adriamycin for the patient?
Right. In terms of prolonging the dosage, I think there was a trial, I don't have all the details to hand, that compared giving doxorubicin as an infusion over 3 days to giving the bolus over a few minutes as we routinely do, to see if this improved the efficacy of doxorubicin. But they were both regimens were equivalent, and given that it's so easy to give the bolus infusion over a few minutes, the bolus treatment, that's what most centers do instead of giving an infusion over several days.
Right, that's efficacy of the treatment. What about cardiotoxicity?
Cardiotoxicity, that study didn't show any significant difference in the cardiotoxicity. Cardiotoxicity-wise, dextrosane is what's most commonly our go-to agent for protecting the heart.
And do you remember if that was in
3%.
all sarcomas or cardiac sarcomas, and if so, what the number of patients were in each group?
I'm really sorry, I don't have that to hand
Okay,
right now.
it's okay.
Yeah.
Adriamycin is such a backbone in sarcoma that when we lose the ability to use adriamycin, the tools that we have to treat are really very limited, aren't they?
Yes, that's it. Gemcitabine with docetaxel has reasonable efficacy. It's not as good as adriamycin ifosfamide, but it does have reasonable efficacy, and we sometimes see very, very good responses to that combination of treatments as well.
And when you've completed your adriamycin, it sounds like you go there first. When you treat that, do you go to the gemcitabine next?
Yeah, so it's either, so if there's been progression with adriamycin, we tend to go to gemcitabine with docetaxel. In patients who...
What about if you've had response? You've had response, now you're going,
Yeah.
oh my goodness, my lifetime dose of adriamycin is here. What do you do next for the patient?
We could give Calyx as a continuous treatment.
And is there a lifetime dose of this Calyx stuff?
Generally speaking, no. We can give Calyx. So, for instance, the patient I presented, he's still on Calyx and has been on Calyx for almost a year.
Why not use Calyx right from the beginning? What's the difference between Calyx and adriamycin in terms of efficacy?
I think it's cost.
Cost is the only thing.
Calyx is a lot more expensive.
Okay. All right. I'm sorry to push you so hard. What do you think about immunotherapy and these immune systems where you get the body to fight the cancer?
Immunotherapy is very interesting. When it works, it sometimes works brilliantly. And we're seeing a lot of headway being made, particularly with the synovial sarcomas and the cellular therapies. But those treatments are very complex. It's going to take a lot of resources to get those kinds of treatments mainstream, if I'm honest. And not every patient is going to be able to handle those treatments, especially if they've been heavily pretreated with limited bone marrow reserve. With regards to immune checkpoint inhibitors, there's certain subtypes like the ASPS, alveolar soft part sarcoma, which we're quite confident are likely to have a response to immune checkpoint inhibitors like the anti-PD-1 or PD-L1 agents. And we know that being such a heterogeneous disease, there might be other subtypes where a small proportion of them would respond. But as things stand right now, there's no good predictive biomarkers for identifying which types of sarcomas, other than the ASPS, would respond to immune checkpoint inhibitors. But there's definitely a lot of work going on there, particularly combining them with targeted agents to see whether we can turn what's regarded as a generally immune cold tumor like sarcomas into a more immune active treatment.